for a lower fine, and this is going to be it, it's not necessary at all to bring a lawyer with you.
Following up on the informal conference for a second, what is it that someone should be bringing to that informal conference, and how should you lay out your case, and how is that informal conference usually? How informal is the informal conference?
It's very informal. Anything goes. Anything you want to talk about or anything you want to bring with you is absolutely appropriate. Let's say, for example, that you couldn't find an MSDS sheet during the inspection. You could bring it with you to the informal conference. Or let's say that you had a letter to a manufacturer asking for an MSDS sheet, and you'd misplaced it, couldn't find it, and in the meantime, before the informal conference, you did find it. Bring it with you. If you were asked by the inspector to do anything at the closing conference, and you have done what the inspector asked you to do, bring some documentation or a photograph or some evidence, if you have it, of how your office has been in good faith in trying to comply with the standards. And that will affect the size of the penalties and how willing OSHA is to reduce.
Is there anybody from the office that you would bring with you, or is this something that you do alone?
I think the owner should definitely be the principal person to go, and if there is a regulatory compliance person, which hopefully there is, it would probably be very helpful to take that person as well.
But we hope that after this program there will be a regulatory compliance person in every office.
Every office, right.
Your question, please.
Okay, what obligations do I have to the people who clean the office after hours?
Depends on whether those people are employees of your office or employees of an outside cleaning service. If they are employees of your office, you have the same obligations to those employees as you do to all your other employees. And that means they have to be trained appropriately on any hazards that might exist in your office, and trained properly to know how to do their job safely. If they are employees of an outside cleaning service, I would recommend to you that you make sure the cleaning service provides them with training on how to clean your office in a safe manner. Legally, it's not your responsibility. It shouldn't be your responsibility. And I think to protect yourself, you should make sure that the cleaning service is one that does provide training to their people.
Are there any instances where a cleaning service had been, called in as, as part of the inspection? In other words, the inspector points some things out. The owner says, well, this is something that the cleaning service, which the building supplies and we have no direct control over, offers to us?
There have been instances where dentists have been able to say, we have no control over something, and it's handled by an outside agency, a state agency, or a private vendor, not necessarily relating to cleaning. And if you have adequate documentation of that relationship and who's responsible for what, OSHA tends to respect that relationship. If you simply say, well, gee, I have an outside cleaning service, I don't really know what they do, it's possible that OSHA might issue a citation to you for exposing someone else's employees to hazards.
And I'd like to pass this on to Ms. Logan. When you showed earlier on the case study of Dr. Doe II and said that he or she was involved with inadequate infection control, inadequate HAZCOM training, mislabeled bleach, a common sink for instruments, and coffee, you said that those citations were all dropped. And my question is, why were they dropped, and what does this then say about what these regulations are supposed to be all about?
In my view, they were dropped for a couple of reasons. One, the complaint, we understand, was filed by an ex-employee, and there was a question about whether or not OSHA really had the proof of those violations that they thought they did when they issued the citations. Secondly, OSHA incorrectly used the new fine structure in that particular inspection before the law went into effect. So they had some technical problems that they couldn't really overcome. Thirdly, the American Dental Association used that as a test case. The dentist very strongly denied that those allegations in particular that you mentioned were even true. And we took it on as a test case, and I think OSHA just decided they didn't want to fight the American Dental Association with this dentist.
Because I think it's important, as those were laid out, it seemed that they just, if they were true, fly in the face of the whole purpose of putting these regulations into effect.
And you're right. And I don't think if OSHA thought they had a case and they really thought those violations existed and they had their proof in order, they would never have dropped those.
Thank you very much, Ms. Logan. Thank you for the wonderful questions. Ms. Logan will be able to answer some questions later on as the program develops.
Thank you.
Our second presenter today directs the ADA's Division of Scientific Affairs in Chicago, as well as the Paffenbarger Research Institute at the National Institute of Standards and Technology in Bethesda. Dr. Enid Neidl will present background on the epidemiology of bloodborne diseases and provide us with practical methods of complying with the OSHA standards of bloodborne pathogens. Dr. Neidl.
Thank you, Dr. Kaufman. You have now learned at some length how OSHA was legally and legislatively empowered to inject itself into the healthcare setting. And you have also learned what your rights and responsibilities are with respect to the new OSHA standard on bloodborne pathogens. In a sense, we've put the cart before the horse because, and now I'm going to use an outrageous mixed metaphor, what has really driven OSHA's engine straight into your office and into every other healthcare setting in the United States is our entry into an era of infectious disease. To be sure, infectious diseases have always been with us. But in 1981, when 5 young, white, homosexual males were diagnosed in Los Angeles with a new and mysterious disease, and then later that year, another 189 young, white, homosexual males were found to have the same disease, we entered a time in our lives when we have become literally obsessed with this tragic epidemic, an epidemic that I fear we will not see the end of in our lifetimes. The story, however, does not begin and end with AIDS, for in the mid-1970s, the dental profession became aware that it was at the 3 times the risk of the general public, which is shown here as blood donors, of contracting hepatitis B occupationally. In fact, at about that time, the mid-1970s, it became very clear that medical personnel in general who have contact with blood, surgeons, blood bank personnel, physicians in general, were at much greater risk to hepatitis B than were the general population. Another very alarming episode occurred at about this time in the mid-1970s when it became known that not only were dentists getting hepatitis B occupationally, but in fact they were giving their patients hepatitis B. And this slide summarizes 9 cases of hepatitis B transmission from dentists to 147 patients. I will call your attention to 2 things on this slide that I think are fairly impressive. One is very macabre, a portent of things that have happened very recently. In 1986, an Indiana oral surgeon transmitted to 9 patients his hepatitis B virus. 2 of those patients died very rapidly. But on the sunnier side of the street, 1987 marks the last time there is any record of a dental transmission of hepatitis B. Lest you think that dentistry has somehow been singled out by a malign fate to be the transmitter of dreadful infectious diseases, here is a slide which summarizes all the transmissions in the medical dental setting. And as you can see, we have the 9 cases involving dentists, and then we have, if my addition is correct, 14 cases of transmissions in medical settings. Not only do we have those, but in fact, in every year since 1987, which was the last transmission by a dentist to a patient, there have been transmissions in the medical setting. Here is what happens annually with people who are infected by hepatitis B. There are 300,000 new infections each year. 75% of these patients who are infected will not know that they have been infected. They may think they had a cold. They may not have any symptoms. 25% or 75,000 will be variably ill, some slightly ill with a flu-like disease, some very, very ill and requiring long hospitalization, and some ill unto death. About 250 of the 75,000 cases will die fairly immediately. Now, what happens to all of these two cohorts, asymptomatic and symptomatic? 19,000 will become hepatitis B chronic carriers. This gives them the real possibility of infecting their patients, their loved ones, their children. Of the 19,000, a certain proportion will die from cirrhosis of the liver, 4,000, and death from primary liver cancer will occur in about 800. Now, not only was the ADA saying dentists use gloves, use barrier techniques, but very soon, in 1982, there was developed a vaccine which was derived from human plasma named Heptivax, and the ADA got very proactive on the subject and urged the dentists to be vaccinated so that they might never be infected with hepatitis B again. This vaccination would confer almost total 100% immunity for all who took it over a period of 6 months. The immunity was expected to last between 7 and 10 years. Fortunately, in 1987, a vaccine was developed through recombinant DNA technology, and a second vaccine, same technology, was developed in 1989. Again, they require 3 injections, conferring virtually total immunity. The striking part about Engerix B, which is manufactured by SmithKline Beecham, is that it provides a somewhat faster immunization. As you can see, it can be given at 0, 1, and 2 months, and a booster at 12 months, and you get 97% immunity from hepatitis B, so that from a practical point of view in your office, you can provide a new employee with virtually total immunity in 2 months. The dental profession's acceptance of the vaccine was, as I said, somewhat slow in the beginning. In 1983, a year after the development of the plasma-derived vaccine, we see 17.2% of dentists have accepted or had accepted the vaccine. In 84 it rose, in 85 it rose, but you see this has been a steady increase, so that now in the year 1991, we know that about 75% of all dentists in the United States have been immunized, and another 8% have markers for natural immunity. That is, they had the disease and therefore are immune. That leaves us with about 15% of the dental community which has no protection against